Okay, thank you. Let's turn to Kevin. I wanted to get the whole story out here first without interruption, and then we'll go around and we'll do some questions, and then we can hear from the measure developer. So, Kevin?
Yeah, I just want to do some comments. I think those last comments, to me, just dug the hole deeper. This is an extremely important issue. You know, there's over 400,000 dialysis patients, 35,000 die each year. Theoretically, half of those deaths could be saved to transplantation. Even if you just increased the amount of referrals by 1%, that'd be 175 patients per year that you would be saving. So this is a very important topic. And the variability in referrals from transplant dialysis centers is huge. And one of the things that they just stated was that each facility has different inclusion-exclusion criteria for being listed. That's crazy. That's one of the reasons why the metric is needed. Dialysis facilities has wide variability. There's one article that was published, and I pulled up in PubMed by Pratzer et al. They're a transplant unit, but found their referral rates from transplant facilities vary between 0 to 75%. I mean, that's unacceptable. And certainly, I do not understand the lack of evidence here. I mean, if we use this as a basis for lack of evidence, we are setting a precedent for throwing out any metric that has to do with delayed or denied care. Because you cannot do a study, ethically do a study, where a control group gets delayed care or denied care. It's not ethical. How are you going to get a group of patients to be on a non-waitlisted list? You're not going to be able to do that. And the risk adjustment for social factors, that to me has a lot of red flags. I have a lot of friends who have Medicaid who cannot get on a transplantation list, and it's very suspicious. You know, they do not reimburse as well. And again, with social adjustments, I strongly feel they need to supplement providers for doing the work rather than mathematically doing away with the problem. So I disagree with this very much, and I think it sets an extremely dangerous precedent for NQF. I do not understand how patient choice is a huge factor. Yes, some patients may be very scared of surgeries, but certainly you have an option that doubles your survival, increases your way of life. By far, the vast majority of patients, when properly educated, are going to choose that. Yeah, you'll have a few that won't, but that's certainly a very small percentage. So for the life of me, I don't understand why we don't implement these. They seem to be very simple, very to follow. It's a huge problem. The referrer that's responsible has a huge financial conflict of interest with this. And this is something I think that NQF needs to approve. And if we do not approve it based upon this reasoning, you then put any metric that's trying to look at increasing access to care or denial of care in jeopardy because you're not going to have a double-blind controlled study. So those are my major comments. I would recommend that the committee reverse the decision of the standing committee and approve this metric. Thank you.
Thank you.